Hi everybody, it is 11:30. As I said, I'm Sarah Green. I'm the Executive Officer of the Health Services Research Association. Great to have you all here for our webinar this morning. I've got a pretty busy session today, so I'm going to be really brief. Just to say that our webinars are free and open to members and non-members, but we do encourage you, if you aren't a member of the association, just to have a look at our website and our other offerings and think about joining us, because we do rely on our member base to keep our activities running. And I've just got a couple of very brief announcements this morning. Firstly, we are currently running our awards program. We are looking for nominations for best HSR papers of the year, and we're running our impact awards. All of those details are on our website, and nominations have been extended to the end of August, so it's a great opportunity to put in a nomination and recognise your colleagues and the great work that's being done in this field. And secondly, we are already well into organising our next Health Services Research Conference, and that's being held in December at the end of 2021, the 1st to the 3rd of December 2021, when we do hope that we'll all be able to meet face to face again. So please put that date in your diary. Couple of housekeeping issues this morning. We can't see or hear you, but if you have any questions, you can type them in the Q&A button at the bottom of the screen, and any comments during the presentations, you can type into the chat button, and what we'll do is we'll put those questions to the panelists at the end of all of the presentations. I am recording this session this morning, and that should be on our website by Monday. And I don't think I have anything else to say. I've probably forgotten something. I'm going to hand over to Megan Campbell, and Megan is from the Australian Centre for Health Services Innovation in Queensland, and she is the treasurer of the association, and Megan's going to chair the session this morning and manage the Q&A at the end. Thank you.
Thank you, Sarah. Hello, everybody. Thank you for joining us today for our latest webinar on what we've learned about national and international models of integrated care for child health. I'd like to start by acknowledging that many of us today are joining this meeting from lands traditionally owned and unceded by local Aboriginal and Torres Strait Islander people. I pay my respects to their ancestors, customs, laws, and creation spirits, and acknowledge that these lands have always been places of teaching, learning, and research. So today we're very lucky to hear from a group of researchers who are leading the development and implementation and evaluation of two novel models of integrated care: Strengthening Care for Children in Australia and Children and Young People's Health Partnership Project out of London. Both these models of care are designed to support primary care through integrated specialist support and aim to keep care closer to home and reduce the burden on the hospital system and improve quality of primary care for children. Our first two speakers, Professor Raghu Lingham and Professor Harriet Hiscock, will discuss the models and share findings from their cluster randomised control trial in the UK. Professor Raghu Lingham is Professor of Paediatric Population Health at the University of New South Wales, Honorary Professor at the Black Dog Institute, and a Consultant Community Paediatrician in the Sydney Children's Hospital Network. He set up and leads the Population Child Health Research Group at University of New South Wales and co-leads the Kids for Adults Clinical Academic Group as part of Sydney Partnership for Health Education Research and Enterprise, or SPHERE. Professor Harriet Hiscock is a consultant paediatrician and NHMRC practitioner fellow. She is Associate Director Research at the Centre for Community Child Health, Director of the Royal Children's Hospital Health Services Research Unit, and Group Leader for Health Services at Murdoch Children's Research Institute. Harriet's research focuses on developing, testing, and implementing novel approaches to keep children out of hospital, reduce low-value wasteful care, and to integrate health, social, and education services to improve health and well-being for children, including those living with family adversity. After we hear from Harriet and Raghu, we'll hear from maternal and child health nurses Mandy, Stephan, and Melanie Wade, and paediatrician Dr. Billy Garvey, who will report on the innovative integrated child and family telehealth project in Victoria's Wimmera Southern Mallee. Thanks. I'll now hand over to Raghu.
Thank you, Megan. Thank you, Sarah. Thank you for the introduction. So I'm presenting the Children and Young People Health Partnership on behalf of a large team of people. And I wanted to stress that from the off. This project has been a long time in development, and hopefully we should have some definitive results from our cluster randomized control trial this time next year. I'd like to particularly acknowledge Ingrid Wolf, who is my co-PI on this piece of work in London, which we set up when we were both in London together. So CHIP stands for the Children and Young People's Health Partnership, and it's an integrated model of care in South London. Oopsie daisy, trying to think about next slide here. Okay. So I am living in Australia now, and a little bit of a plug for our research team, which is the Population Child Health Research Group at the University of New South Wales. And one of the key strands of work that we have set up here in New South Wales is transforming health systems. And so these are our three research themes: healthy beginnings, transforming health systems, and priority populations. And we're embedded within a clinical academic partnership here in New South Wales called SPHERE. So understanding the problem. What is the problem for child health going forward? There's approximately 20% of deaths across high-income countries such as the US, the UK, Australia, and New Zealand are thought to be preventable through better clinical care and patient self-management. 60 to 70% of children who died in the UK between 2001 and 2010 had a chronic condition requiring frequent contact with the health system. For example, 75% of asthma admissions are thought to be preventable by better primary care. And there's also a steep rise in both emergency admissions and outpatient appointments in high-income countries for children with an array of different conditions, specifically those with chronic conditions. So what are we seeing in terms of health outcomes? This project is based in the UK, so I'm presenting UK-based data. UK data shows that actually mortality in terms of infant mortality and 1 to 4 year mortality is increasing. So not only is the system actually failing in terms of our increasing needs, but in terms of outcomes for children in the UK, we're not doing as well as we potentially could do. In terms of healthcare quality, the UK is lagging behind many countries in Europe in terms of key health indicators. Less than 60% of care, and this is an Australian study by Braithwaite, is thought to be, only 60% of care is thought to be evidence-based or follow evidence-based guidelines, and about 30% of health expenditure has no measurable effect or justification. So not only are we failing children in terms of worsening health outcomes, we are having a system that is inefficient and not evidence-based. That 60% evidence-based care is actually worse in primary care, and where the percentage is about 40 to 50% of primary care consultations for paediatrics and child health follow evidence-based guidelines. Taking asthma as an example, the UK has the highest admission rates and death rates in Europe. 70% of admissions are avoidable, and 65% of children's deaths from asthma are potentially preventable. And as a health system, we are not functioning as we could do. As I've mentioned, there is this huge increase in ED attendances, and we're seeing a huge increase in outpatient referrals also. There's a 100% increase in outpatient referrals to the Children's Hospital in Melbourne, and a 32% increase in referrals to the Sydney Children's Hospital networks. Those are two of the biggest healthcare providers in the country, and Harriet will be mentioning this in greater detail for strengthening care for children. So in summary, what's the problem? Health is getting worse for children, and it's not being prioritized. Healthcare quality is not good enough. We need to do something about this. And the health system itself, with the increasing needs, is not managing to cope with that increasing need. We did a systematic review looking at models of integrated care, and this has been published in 2020 in Paediatrics. And that showed that models of integrated care had a significant increase in the health-related quality of life of children. We showed no significant decrease in ED attendances, but we were looking specifically at randomized controlled trials. And when we do a meta-analysis of randomized controlled trials, these are few and far between when it comes to ED attendances. But we did show a significant increase in health-related quality of life from integrated models of care. How can we solve the problems that I've put before you? Well, integrated care is a potential solution for this. And what do we mean by integrated care? We mean integration between primary care and secondary and tertiary care providers. We mean integration between health and education, between health and social care. We also mean integration between primary prevention, secondary prevention, and tertiary prevention in terms of health and illness. What we've developed within South Thames, South London, is a model of integrated care called CHIP. And we've developed a logic model thinking about using the WHO building blocks for health to actually model and shape our intervention. So what are we thinking about? We're thinking about leadership. We're thinking about, financing. We're thinking about how we can change workforce. We're thinking about how we can use technology and how we can use analysis to actually inform our health system changes. What we're delivering is both targeted services for children and young people with particular tracer conditions and universal services for all children. And CHIP is an exemplar. We've just got targeted services for exemplar conditions, but it's basically just a system change where we're showing what can be potentially done. We're looking at changes at the level of the family in terms of self-care, in terms of workforce, in terms of supporting primary care specifically, and the system itself, where we're thinking of changing the system where more care is delivered within the community. What we're wanting to do is have improved child health, better healthcare quality, and strengthened health systems. So as I've mentioned, CHIP is a clinical academic partnership in South Thames. We're testing at scale new ways of delivering better care for children using a whole of systems approach. We've got a partnership between hospitals, primary care systems, commissioners, those are the planners and purchasers of health systems in the UK, local government, and primary care. And this partnership is absolutely key and why it has taken so long to get this project off the ground. So as I've mentioned, we can think of CHIP as, if you like, a child home, where you've got these building blocks, so WHO building blocks, propping up the universal services and then the targeted services for children with ongoing conditions. So what do we mean by ongoing condition care? We're talking about tailored care for children with ongoing tracer conditions, epilepsy, asthma, eczema, and constipation. Care for mind and body, so the integration between physical health and mental health. Population approach to care with universal coverage and early intervention. We also have CHIP clinics, which are basically supporting primary care physicians to be able to deliver better value care. So we've got a one-stop approach to expert care, where paediatricians and GPs sit together in co-consultation clinics. This is supported by online and phone support to the GPs and case discussions. Clinics delivered in primary care, GPs and paediatricians working together and learning from each other. This is not paediatricians telling GPs what to do, it is paediatricians learning from GPs and GPs hopefully learning from paediatricians too. So it's that mutual respect is absolutely essential for those CHIP clinics. So how does this fit into the local child health landscape? We've got, within the GPs, we've got urgent care through consultant connecting apps and A&E. We've got non-urgent care through GP child health and ongoing condition care. We've got child health checks via a portal where children are actually with these tracer conditions we reach out to them and invite them in to fill out the child health check and then having tailored support for them. Health packs for families, and then CHIP health team triages and develops and delivers tailored care. And this tailored care is absolutely essential. So what we're doing for our targeted services is reaching out to children with asthma, eczema, epilepsy and constipation, and actually going out and reaching them through primary care, through a system called Call Recall, where we actually say to those children and invite them in to fill out the health checks. We then offer them tailored care to their needs, including mental health support. We're then evaluating this using a cluster randomized control trial. And we're using a cluster randomized control trial because this is gold standard. What we're trying to do is use randomized methodologies for this health service transformation. Our unit of randomization is a GP hub consisting of 2 to 4 GP practices. We have 12 enhanced usual care practices and 11 full CHIP model practices. What we mean by enhanced usual care is decision support, paediatric hotline, school-based emotional resilience building, and minor illness programs. And then within the full CHIP model, we have all of the enhanced usual care, plus planned care for long-term conditions and increased supports for GPs to treat the young people. We're doing a population level evaluation, looking at health service use on 90,000 children across Lambeth and Southwark. And if we include our pilot areas, it's 120,000 children. We've got a tracer condition evaluation where we consent children and we get individual consented parent-reported outcomes, including mental health and health-related quality of life. We're also doing a detailed process and implementation evaluation and a detailed economic evaluation, looking at cost effectiveness and cost savings of the system. So what we're trying to do, as I've said in the logic model, is strengthening the CHIP health system, the children and young people's health system, improve child health and improve quality of care. And we have outcome measures to look at each one of these in turn. What have we achieved? Well, first of all, we've strengthened the health system itself. We've been able to develop a leadership and partnership program. We're thinking about financing and negotiating, promoting cooperation, and thinking about mainstreaming a lot of the interventions that we've put into place. We've got a CHIP workforce in place with paediatricians, GPs, mental health physicians and nurses all working together. We've got a patient portal, so this is our technology, where patients, parents are able to look at our resources and be able to fill in questionnaires so we can tailor our services. And we've got interoperable patient notes, which promotes interdisciplinary working. And this is something really important from an Australian context, that the ability of primary care physicians and paediatricians to have the same interoperable computer systems. And then we've got analytics, we've got Call Recall enables early intervention, and I've described what Call Recall is. We've got a service evaluation and a research evaluation, and I'm going to be presenting a little bit of the service evaluation data. Because this is a cluster randomized control trial, we're waiting for unblinding, which should happen this time next year. And then we've got new services. We've got a biopsychosocial model of care for children and young people. We've got vertical integration. So we've got a one-stop shop between GPs and paediatricians and mental health physicians. We've got horizontal integration, where we've got tailored interventions to children's needs. And we've got longitudinal intervention where we've got age-appropriate care for the child's needs. So for our first wave and early results, our first wave of activity we were able to reach 90% of our eligible population. This is just from the trace condition evaluation. 61% of children with asthma had poorly controlled symptoms. These are children that are responding to our call recall system. Okay? So actually there's a big unmet need here, even though a lot of these children are known to the system. 72% of children with constipation had significant problems needing intervention, and 76% of children with eczema had moderate to severe symptoms. Across all conditions, 28% of children had high or very high scores on their mental health questionnaire, 28% of children with chronic illness, and 12% of parents expressed concern over their own mental health. So this is what we're finding out from our biopsychosocial screen. So the need is there. We've found that 68% of our health checks were completed by children from ethnic minorities, which reflects, but actually increases the number of children within Lambeth and Southwark. Lambeth and Southwark does cater for a lot of families from low socioeconomic groups and high needs, and a lot of those families are from ethnic minorities. But the fact that we were able to have a higher than the population proportion of those children from ethnic minorities was really actually reassuring in terms of reverting the inverse care law. 38% of parents reported housing concerns. 8% of families did not have access to food, and 25% of families were having problems paying their bills. And if you do not ask about these problems in terms of the psychological and social needs, we will not be able to tailor services to those needs. Early intervention and holistic responses are absolutely essential. Our early results suggest improved healthcare quality and reduction in ED use among patients with asthma, epilepsy, and constipation who participated in CHIP services. We estimated from our service level evaluation that we had, from this provisional data, that we had 288 fewer ED contacts for asthma per 100 patients per year, with 120 for epilepsy and 60 for constipation. We had fewer admissions, and we had a net saving for the asthma service alone, projected from year 2 onwards. So from year 2 onwards, the new system actually pays for itself. That's a real kind of whistle-stop tour through the CHIP program and our very early results. I'm really looking forward to sharing the definitive results for you when we meet in person in December 2021. So thank you very much for your time, and happy to take questions now or at the end. Really wanted to emphasize that this is very much a team. I'm presenting on behalf of a very large team. The photo does not give us justice, and we are a huge clinical and academic partnership. And with Harriet and colleagues in Australia, we're thinking about doing something very similar here in Australia. So thank you very much.
Thanks, Raghu. We might leave questions to the end, I think. If everybody who's watching would like to, if you do have questions for Raghu, can you please put them into the Q&A tab, and I'll help moderate those towards the end. And if Harriet can pop her slides up now, we'll move on to her.
Thanks Raghu, and thanks Megan. So I'm now going to take you back to Victoria and, as you'll see in a minute, New South Wales, and talk about the work that we've been doing alongside what Raghu's been doing, and before I really was aware of the CHIP model and what was happening. And it's whenever you think you have a good idea, there's always someone or a few people around the world who also have a good idea. So today I'm going to talk about strengthening care for children, which is and the pilot in particular of our novel integrated GP paediatrician model of care. So it's taking a little while to move itself down. So similar to what Raghu was talking about in the UK, we have demography that we are trying to deal with in Australia. So over the last 20 years, Australia's paediatric population has grown by 18%, or close to another 1 million children. However, when we look at the Medicare data, children make up an even smaller proportion of general practitioner visits, and that's largely because our GPs are spending a lot of time managing complex care and aged care. But I'll show you some data in a minute. Similar to the UK, when you look at who's turning up to Victorian emergency departments, the biggest age group is 0 to 4-year-olds. And as Raghu said, over the last 3 years, referrals to non-surgical outpatient clinics at our children's hospital have increased by 100%. And pre-coronavirus, for some of our outpatient clinics, the wait times are now 12 to 18 months, which of course is not acceptable. So here's some data from a paper by Garvey, who's a health services researcher who came and spent a sabbatical in Melbourne for a few years. And this is looking at attendances, trends in attendances from 2002 to 2013. Here's the age group here, and what you can see is 0 to 4-year-olds are the biggest age group coming to all Victorian emergency departments. This is not paediatric EDs. So when I was looking at this issue for our healthcare system, I found the UK was facing similar problems, and I found a model called Connecting Care for Children that had come out of some other colleagues in London that was bringing paediatricians into GP practices. And the 3 key elements of their model was monthly case discussions between the GP and paediatrician at the GP practice, co-consulting sessions, and email and phone support for GPs in between. So they've published an evaluation. It's not a randomised controlled trial, so it's not a gold standard evaluation, but they've published their results in Archives of Disease in Childhood, and they found that families through this model had increased preference to see the GP and increased confidence in their GP to provide care for their child. GPs reported improved knowledge of child health and increased trust and collaboration with paediatricians. And they reported reductions in new hospital patient appointments, specialty referrals, and ED attendance. So we decided we'd pilot a version of this in Melbourne. So the aim of the pilot really was to look at feasibility and acceptability of an integrated GP paediatrician model of care. And what we did was we funded 2 paediatricians from the Royal Children's Hospital, so Dina Parbu and Gihan Roberts here, to go to the 5 clinics on a monthly basis to run case discussions, and for a session a week, so a half day, to do co-consulting between the GPs and the paediatricians, and to provide that support in between. We wanted to support GPs to reduce referrals to the hospital system, to improve the quality of their care, and to reduce parental requests for paediatrician referrals. So we collected baseline data. We went live back in April 2018. We ran the model initially for 8 months, but it was so successful that the PHN, our primary healthcare network, funded us to run it for another 4 months. We collected interim data for 2 weeks over this period, and then outcome data once the paediatrician had left the clinics in February, March last year. These are the measures. So in terms of collecting data on GP consultations and referrals, we actually used a piece of software called Granite software, developed by Professor Dougie Boyle from Melbourne Uni. And this software can be remotely installed into GP's electronic medical records, or EMRs. So the GP workflow is not interrupted. They record their consultations as per usual, and then every 2 weeks we can pull that data on diagnosis, tests made, medications supplied or prescribed for that child. However, what GPs don't routinely collect is referral patterns. So we had to train up our GPs to do that. And we actually had some quality improvement payments that we paid in instalments depending on how well the practice did that. We did online surveys of families and GPs, so we had research assistants in the waiting rooms of the GP practices with iPads loaded with surveys. And then when families agreed, we did qualitative interviews with them at follow-up about the model, and the co-consult data and the case discussion data was all recorded by the paediatricians when they were conducting those co-consult sessions or the case discussions on that monthly basis. So what did we find? If we first of all look at acceptability and feasibility. So really the monthly case discussions went down extremely well with GPs and they all thought that was feasible and acceptable. They thought that the email and telephone support was also feasible, but I'll show you some data. They didn't really use that often. In terms of the frequency of co-consultations, we initially ran with weekly co-consultations, then we dropped down to fortnightly after 8 months. And certainly that was easier for the GPs because they had to get used to doing half-hour consults with the child and the paediatrician. And typically they'll often just do 10 or 15-minute consults. The paediatricians reported that this pilot had strengthened their links with health professionals and had been beneficial, they thought, for the kids. So in terms of referrals and what happened, we saw a drop off from pre, interim and post in referrals, particularly to the emergency departments. We saw less of a drop off in referrals to outpatient clinics, and once the paediatrician left, then this jumped up back to really the referral rates to outpatients from the original baseline data. There was a big drop off in referral to private paediatricians in the area. And this is just showing you the actual data there. What about the families? So we surveyed around 284 families, which was around about an 80% response rate. And this was whether or not the families had seen the GP and the paediatrician in a co-consult. We wanted to get an overall feel of what families thought as a result of their GP having this opportunity to interact with the paediatricians. So not all the families had seen a paediatrician with their GP. But here's the data from the baseline surveys, and we just followed up the families with the surveys halfway through the model. And what we can see is improvement in all the outcomes. So completely confident in the GP to provide general care for my child went from 78% to 94%. More likely to prefer GP care as their first choice for follow-up care went from 65% to 83%. You can see the GP providing enough information or concerns or questions, and the GP can manage and coordinate short and long-term care for my child went from 76% up to 90%. So certainly the families like the model. We did 13 interviews with families to get some qualitative outcomes about the experience in the model. And here's what they said with some quotes. It was really good for us. The GP already had some background on the child. That was our normal medical centre. We weren't really having to go over the same stuff again because they were already aware of what was happening. It saves us so much time. Just having to go to the children's hospital is almost like a full day's event. Doing it locally is excellent. And here's a bit about cost. So the paediatricians in our model were paid for by the hospital because Medicare will only allow one provider to bulk bill Medicare or bill Medicare. If there's a GP and a specialist, it's got to be one or the other. So the family's got this model with no out-of-pocket costs. What about the GPs? Well, we had 49 GPs participating at the highest point of the model, and GPs move around a lot in general practice over 12 months, I've discovered. So I'm just showing the data from the 24 GPs who did surveys at baseline, interim and outcome. And again, we saw improvements in all outcomes in terms of knowledge and skills of managing children, knowing how systems are organised. And we also looked at their use of health pathways, which is point of care clinical decision support provided by the PHN. Certainly GPs thought this strengthened their links with other child health professionals and had increased their professional knowledge, skills and confidence in child health issues. So this is what some of the GPs are saying, and I think I'll just really draw you to this thing. One of the biggest issues for GPs is managing developmental and behavioural problems in children. And our paediatricians taught the GPs to use freely available questionnaires that the parents and the teachers could fill out. They taught the GPs to score those questionnaires, and then based on the results of that questionnaires, the GPs then streamlined their referrals either to a psychologist or a speech therapist or a paediatrician. So I think that streamlining of the process is one of the really exciting things. We also heard from the GPs that having a paediatrician there gave them the confidence to use existing resources like the Royal Children's Hospital Clinical Practice Guidelines and health pathways. In terms of quality of care, we saw a reduction in unnecessary testing for or prescribing for common conditions. For example, a reduction in prescribing of steroids or antibiotics for bronchiolitis, and a reduction in use of acid reflux medications for crying babies. This is just data on the co-consults. So there were 624 children seen in the co-consults, and the majority of these co-consults resulted in no further referrals, with the child returning to their GP's care. The big issues that they talked about, you'll see here, is developmental behavioural problems. This is just data from the 50 case discussions that were held over the 12 months. We had 378 clinicians attending. And again, the biggest thing they wanted to talk about was developmental and behavioural problems, followed by allergy and asthma, and then constitutional issues and musculoskeletal issues. As I said before, we didn't get a lot of use of the email and telephone support. Perhaps some of the email support and telephone support went up once our paediatricians were only in the clinics fortnightly rather than weekly. So I guess the wider impacts of this project is we've started to create a medical home for children. There's ease and comfort for families to be seen at their local GP clinic rather than having to navigate a busy hospital system. There's greater continuity of care. Children are seen quicker. They're not waiting on the outpatient lists or in the ED as much. There's earlier implementation of health management plans, which is really important for children's development. And greater GP confidence means greater quality of care for all children seen in those clinics. So given this result of the pilot, we applied for and were lucky enough to get an NHMRC partnership grant, which will be a 4-year grant in collaboration with Raghu and other colleagues. So we're going to run a stepped wedge trial to really see if this model is effective and cost effective. And we'll do that with 22 GP practices across Victoria and New South Wales. So we're in the setup phase at the moment. But next year, COVID depending, we hope to be in the GP clinics, and every month we will randomly allocate a Victorian and New South Wales GP clinic into the intervention, run it for 12 months, collect sustainability data, and really see if this model can make a difference. So as Raghu has also said, this is a partnership, and I'm really excited about this work that we're doing with our primary care and healthcare colleagues in the specialist settings. And I too would like to thank the team that was involved in the pilot study. Thank you. Now I am going to hand over, if it's okay, Megan, to my colleagues from the By 5 initiative, and they come out of the Wimmera Southern Mallee, and I actually don't want to stop sharing my screen because we have put the slides together. So just let me get to the correct slide. So By 5 is a place-based project that takes place in 20% of Victoria, but just sees 1% of the population. And the partnership really aims to ensure that families and young children across the Wimmera Southern Mallee region can get access to paediatricians' care and specialist care. It was made possible when 5 organisations pooled funds to employ a remote paediatrician 1 day per week, Dr. Billy Garvey, who we'll hear from. And I think one of the really exciting benefits and timeliness of this project is it was always designed to be delivered by telehealth, and that's where we're all going to be moving post-COVID. So I'm really excited today. We have talking about the project 2 maternal and child health nurses, Mandy, Stephan and Melanie Wade. Both were born in the Wimmera, studied in Melbourne, and then returned to their communities to practice. And between them, they have more than 50 years of experience in nursing. This really provides a rich local knowledge and practice wisdom that's guided the really unique shape of this project. And they're joined today by Dr. Billy Garvey, who's the paediatrician from the Royal Children's Hospital. So I'm going to hand over now to Mandy to introduce herself and the project. And Mandy, you tell me when I need to move my slides.
Okay, thank you, Harriet. I'll just give you a little bit of a picture of myself and where I am. I was born and raised in Conira, a small country town on the South Australian border. My father was a farmer and my mother was a nurse, and I'm the oldest of 5. I completed registered nurse training at Box Hill Hospital in Melbourne in the eastern suburbs and midwifery training at the Royal Women's in Melbourne. Returned to the Wimmera to work at the closest maternity hospital back then, which was Nil. On meeting my husband-to-be, the impractical combination of shift work and farming life saw me return to Melbourne for more study. And in 1987, I married and was employed as the local MCHN midwife, a great position giving true continuum of care to families. In the 1990s and 2000, brought many changes, shire amalgamations, droughts, and a change in how services were delivered saw rural maternity hospitals close. These closures contribute to a huge population shift in the Wimmera Southern Mallee. As services left, so did people, a spiral that continues. I continued study, returning to university and gaining a Bachelor of Nursing Science and then a Master's in Nurse Practitioner. In 2020, the Hindmarsh Shire Maternal and Child Health Service is delivered through the West Wimmera Health Service, and my role encompasses antenatal care, midwifery domiciliary care. My shire, Hindmarsh, yep, we've got a picture, good. Right there, yep, thanks, Harriet. Has around 60 births per annum, and I work out of the centres of Nil, Japarut, Rainbow, Dimboola, as well as doing home visits. About the Wimmera Southern Mallee. The Wimmera Southern Mallee is where I live and I love. It's one of the greatest grain growing areas of the world, based on broadacre agriculture and a small manufacturing businesses, with Horsham being the main regional centre. The population is increasingly vulnerable and shrinking. Services that are taken for granted in the city are not available locally. The stress of not having what you need locally has forced many people out of the area. Increasingly, the area is made up of people with generational wealth and land, and people who come to the area seeking escape and to access cheap housing. The next slide, Harriet, I think, yep. This project is for maternal and child health nurses in the Wimmera Southern Mallee is the best thing since sliced bread. The project has supported around a dozen of us to come together on a fortnightly basis for case study seminars. The topics for the seminars are chosen by nurses, and at each seminar we do 3 things. Billy presents guidance on best practice and recent changes to practice or knowledge in respect to practice. For example, the latest advice from the Royal Children's Hospital on the use of reflux medication. The nurse or the nurses present a case study, and this involves presentation of a case that we've seen in our practice. We discuss the presentation of the case and the approaches, referrals and actions that we have taken. We have opportunity to ask for advice from our colleagues around their practice and any other resources they have that may have been useful. Finally, we have a facilitated discussion about the implication of the cases and problem solved together. The By5 coordinator follows up by distributing resources and taking any policy implications to the governance group for the project, which is made up of a range of policy and practitioner expertise. At the beginning of the project, and then more recently, we've come together to think about how to keep designing the project and the program to meet our needs. The benefits of the case study seminar program and our involvement have been the following. See that we have influence in how the project works, building our enthusiasm for working together via Zoom, sharing resources and learning from colleagues using real case studies, cementing our knowledge and seeing others manage cases through to the end of involvement. coaching and confirmation from Billy to reinforce our practice, and thinking outside the square about how we manage families, especially in our environment being so remote, and developing greater trust and understanding as colleagues. The changes we are thinking about are going to be a locally tailored approach to referral that can help us develop a stronger alliance with our GPs and allied health colleagues. Also, to continue to ensure that we have a structure in place to continue with joint learning in a case study environment, which provides such rich sharing and ensuring that this learning is recognised by continuing professional development points. The work we do together reminds us of how complex our jobs are and how vulnerable our communities are. Working together like this has added a great deal of satisfaction to my work and has shown me how much we are able to influence the system when we all work together. As the saying goes, no one is as clever as all of us. Finally, I'd just like to say this. I feel privileged to be in this position. This project has given hope for me, and I hope to many families that live in rural remote communities. Where a person lives can tell you so much about their beliefs and values. With telehealth models and different referral pathways, I hope change will improve health outcomes for rural and remote families. Thank you.
Thank you, Mandy. Fantastic. Megan. Melanie, apologies.
No worries. Thank you, Harriet, for handing over, and thanks, Mandy, for your insight into the great stuff that we've been learning through this project. So my name is Melanie Wade, and I'm a maternal and child health nurse. I was born in the rural city of Horsham and completed school there before studying to become a registered nurse, midwife, and then maternal and child health nurse. I returned to Horsham to practice and live here with my husband, our two sons, 7-year-old and 9-year-old boys, and my 19-year-old stepdaughter. Currently, I work at the Horsham Hospital, Wimmera Healthcare Group, as an associate nurse midwife unit manager, in addition to working at Horsham Rural City Council as a maternal and child health nurse and the immunisation coordinator. I'm one of 5 maternal and child health nurses practicing at Horsham Rural City Council, which has 240 newborns enrolled annually and 1,400 active child clients aged between 0 and 6 years. My particular professional interest is in childhood constipation, immunisation and atypical development. Through this project, we've been able to identify families we believe would benefit from a consultation with a paediatrician, but who we think could be managed locally with a bit of support. There are no permanent paediatricians practicing in the Wimmera Southern Mallee. We have some visiting professionals, but they can have really long wait lists and people may need to travel to see them. We feel really skilled in our work, but families increasingly seem to want the reassurance of a paediatric specialist, so a co-consultation model seemed to make a lot of sense. One example I can provide where Dr. Billy and I have worked together was with a rural family living on a farm who had 4 children. The 4th child, a 3-month-old, was persistently unsettled and had not responded to the typical management strategies that work in the maternal and child health service. With this family, we were able to use telehealth to link the family, maternal and child health, GP and a paediatrician up online. In doing this, we provided timely access to Dr. Billy, the paediatrician, without the family having to travel outside our region. As professionals, we were able to work together using local services and support the family. The benefits of the co-consultations we have identified are it enables families to have timely access to a paediatrician, avoid parental frustration at long wait times and turnaround. We've been able to build our confidence in providing high quality referrals, build our confidence and that of families that we are providing good quality and best practice care for our families, holding families in the community and helping us build a stronger alliance and understanding with GP colleagues. My key message about this specialist paediatric support model is that there can be a wait of up to 2 years to see a specialist at the Royal Children's Hospital. So we're fortunate to be able to help our local families access a paediatrician with very little wait period. It is also beneficial for myself and my maternal and child health nurse colleagues to be able to work collaboratively with such a highly skilled and knowledgeable health professional. It definitely provides us with learning opportunities to ensure we are providing the best, most accurate and up-to-date evidence-based information and practice for families in the Wimmera region. We have, as a part of this project, invited the GPs of families participating in the telehealth consults to attend and be involved. Dr. David Wilson from Lister House Clinic in Horsham has participated in telehealth consults as part of this project. The great thing about this is that Dr. Wilson can then provide localised medical follow-up in collaboration with Dr. Billy at the Royal Children's Hospital. I'm now handing over to Dr. Billy to provide a little more information from his perspective.
Hi, thanks Melanie, that was great, and the same from Mandy, and I have to say thank you to both of them for speaking because they're both very busy and both two exceptional clinicians that support a lot of families in this community. Some of these photos are a bit embarrassing but show the involvement that we had leading up to what started with the initiative of co-consultations in the seminar program. And that's really been the benefit of this program, is that we had such a long lead time with co-design, really looking at what the need was in the community, not going and telling them what we thought. So since February this year, we've been using 3 different approaches. One has been a broad health literacy approach in the community, and that's a lead on from what you see the photos of, where we had community consultation and seminar programs around common development and behavioural issues in childhood, and that was really well received and is something that we plan on doing in the future, either via telehealth in the setting of COVID or waiting for things to open back up a little bit more. The other 2 elements have been the seminar program, which is a co-learning seminar series that we've been doing now we've just had our 7th, and these are topics that are chosen by the group, and we all then talk about it from a case-based perspective and learn together. It's been a real privilege to be part of that. I've certainly learned a great deal and it's been a lot of fun. And then the other is the co-consultation model, and I think it's really important that this is one of the projects that shifts the narrative of telehealth about being a second best option, because I think that what I've seen with Mandy and Melanie and all of their colleagues is actually better practice than what I participate in other clinical situations where I get a letter. I'm not able to consult in real time with the other professionals that are involved. And it's been really insightful around that, because we're supporting families in real time, working together and sharing the expertise that we have. It's diverted over 80% of the referrals to the Royal Children's Hospital, which has, for some cases, over a 2-year wait. We're able to see the families quickly. There's a lot more value in that initial consultation because of how thorough the referral process is. These experienced clinicians that have been holding these families in the community for a long time, and it's only with a little bit of additional support that we're able to help families to stay in those communities. We've also not only diverted the majority of them to never needing to come to the Royal Children's Hospital, we've also been able to hasten some of the follow-up within other specialties within the Royal Children's Hospital, because we're able to collect so much accurate information with people in the community. I know we're about to run out of time, and I know there was 10 minutes of question time, so I don't really want to cut in on that too much, but I'd just really like to say that this program has benefited from the maternal child health nurses that have really made a big sacrifice to participate in this and been very trusting of us with their time. And we're also looking at really broadening that out. We've already had some consultation with family services. We've talked with 5 general practitioners in the region now who are all very busy, but they've participated in co-consultations with myself, the family and the maternal child health nurses as well. And we've had a number where schools, educators and allied health members have also been a part of it. So has huge promise to actually be a better way of delivering care than driving 4 hours to come and see a specialist that you'll spend 30 minutes with and may or may not be helpful. So I might finish my lecture there. I'm more than happy to be contacted as well, but maybe we'll have some time for questions if anyone has any.
Thanks so much, Billy, and to Mandy and Melanie for your talk there. We might start with you guys first and move our way backwards, seeing you've just spoken. So I might get you to pop back up, Billy, and ask a couple of the questions here. You just mentioned that you've actually just started pulling in some of the GPs and being able to contact some of those. That was some questions that people had online, was are the GPs being included in this? And also are the Aboriginal services being able to bring in to help families as well?
Yeah, so a really good question. We're doing it a little bit on a shoestring budget at the moment, but we've been really proactive in seeking out the general practitioners. So they're really busy people though. There's, I think, for over 50 unfilled GP positions in this region. So those that are able to see people are very busy, but it's been really important to keep them in part of the process. And the maternal child health nurses, I hope Melanie and Mandy would agree with that we've been really trying not to bypass them because they're really valuable in this process as well. And then other services which have been mentioned, yeah, we're really trying to make sure there's a holistic approach, including not just health, but education and family services as well.
There was a question from someone else about whether the paediatricians, for example, elsewhere in Victoria, like the paediatricians in Ballarat, could be linked into the program and why it was just you at the Royal Children's.
Yeah, so we've been talking to some of the Ballarat paediatricians as well who work in that area. I think there's a different approach that they're using. There's some of the visiting paediatricians are very acute care focused and supporting deliveries and acutely unwell children. There is some outreach services that are quite impressive that are happening out of Ballarat, but they've also got long wait times and difficulty with resourcing. So we're really prioritising collaborating with existing services.
Cool, thank you. There are a couple of questions for Harriet. I'm going to go back to you now around the paediatrician embedded in the GP clinics. So one of the questions was, it was interesting to hear that the outpatient referrals for peds returned to baseline after the peds had left the clinic. So the question was, do you have any idea why that was, or do you have any ideas on how to tackle that?
Yeah, I think there's a few reasons. I think one of our paediatricians was particularly good at trying to keep the care in the GP practice and perhaps was straying a little bit into what we'd see as quite specialist care. So when they left, that wasn't something the GPs could keep holding on to. But I think in this next trial, we'll need to do a bit of a deeper dive into that. I think the corresponding reduction in referrals to private paediatricians was really about the developmental behavioural stuff and helping the GPs better streamline referrals, that because not every child needed to see a paediatrician. They could have been managed by an allied health professional, particularly a psychologist.
One of the other questions was about the cost and whether it's going to be sustainable for the hospitals to keep keep paying the paediatricians.
Yeah, so this is interesting. Our hospital's really bought into this, and Raghu can probably talk about it because we have to think about this for the partnership grant. I see there's 3 funding revenues that are possible. One is the hospitals, but they'll only do it if it keeps kids out of hospital. The other one is the primary healthcare networks who do have the power to commission services. So if they think a lot of PHNs want to create a medical home, particularly those with large numbers of children and families, so that's an option. The third option, which is the holy grail, is a Medicare item number that allows a GP and a specialist, any specialist, endocrinologist, rheumatologist, psychiatrist, paediatrician, to see a patient together. And the RACP, the College of Physicians, is particularly advocating for that in the context of telehealth post 30th of September, and our pilot work is being used as evidence to support that this model can actually improve care for patients. So, Raghu, I don't know if you want to add to that at all.
Yeah, I've been really interested in the Australian healthcare system since I came 2.5 years ago, in terms of the fragmented nature of it, in terms of where the funding comes from, etc. And actually that if you're thinking about the system as a whole, it's a no-brainer. You know, if you're thinking about actually reducing hospital admissions, reducing hospital-based care, you know, supporting primary care and increasing quality of care to children closer to home, absolute no-brainer. But the system is actually almost working against itself because of the funding structure. So we need to, it's not, we've seen in COVID that things are possible and things move incredibly fast when people have the will to do things. So it's an example of actually thinking about those building blocks of health systems and finances is one of the keys. So as Harriet said, the Holy Grail is what we want.
Sarah, do we have time for one more question, or do we need to wrap it up there?
People are still online, I think. Carry on, yeah.
Okay. I just have one more question for you, Raghu, that came online was, is there any known reason for the increase in mortality for the children, particularly in the 0 that you're seeing recently?
So obviously one of the big things is obviously prematurity, and the changes in prematurity and definitions of prematurity. When I started off as a paediatrician, 24-week gestation, anything on any child under 24 weeks gestation would be thought as, you know, not really viable. When I'm now, it's the gestational age is decreased to say 23 weeks or lower even in some cases. And so that areas of viability for prematurity is really important. In terms of the changing demographics, I think there's an increasing inequalities actually, and poverty has huge amounts to play in our increasing child mortality. So as we know, the rich are getting even richer, and poor and children are actually getting poorer. And so it's not just that inequalities are increasing, it's actually generational inequalities are actually increasing. So actually child health is actually funding older people's health, which is a very political thing to say, but it's true, you know. And so we need to think about that. And in terms of preventable changes in terms of epidemiological shift from infectious diseases to more chronic illness before COVID, change that completely. There was a change in terms of chronic illness and the need for more management of chronic illness.
Thank you. There was one final question for Harriet before we will wrap up. Natalie just asked if there was any GP paediatrician model. How is it determined which children are seen by both practitioners? Was it on a basis?
Yeah, that was the GP decision, Natalie. So very much if they felt they needed extra support or wanted to learn more about that particular condition, then they had to see the family first and then they referred to the paediatrician. And it was interesting because within 2 weeks of the model opening in one of the practices, families were on the phone saying, can we see the paediatrician? So the whisper went around the family groups very quickly, and we had to educate the admin staff that wasn't possible. It had to be a GP decision of who they wanted to co-consult with.
Interesting. Well, thank you so much, everybody. It's been fascinating. We're getting lots of feedback through on how wonderful you've all been. Really appreciate you coming on board and talking to us about your programs today. Harriet, good luck with the trial coming up. It's a beautiful design. I like the step wedge design. I think you'll get fantastic results out of it, and we'll all look forward to hearing you come back in a couple of years' time and tell us about that. Sarah, was there anything else you needed to finish off on?
No, nothing else. Just to remind people, we'll get the recording up by Monday. So if you've got colleagues who are interested, point them to our website.
Thanks very much, everybody.
Thanks, everybody.
Bye-bye.